Hey guys, welcome in. My name is John Rivera, and I'm going to go ahead and review Chapter 11 with you. For those of you who may not know, Chapter 11 is risk management in high-risk hospital departments. So specialty departments that may need more risk management um, or may need more risk management practices associated to protect themselves. So basically, we're just gonna go ahead and preview. We'll hop right into it. I know it's quite a bit of information. So I'm gonna go ahead and start with slide 2. Slide 2, I basically am just overviewing the aim and what our response goals are for the chapter. What are we trying to get out of this? What are we trying to learn? I think the main things we're trying to learn is the ability to identify the different departments, understanding the different capabilities and roles of each department. As you'll see later on, the capabilities are a big thing. Based on what we can and cannot do, we need to make sure that that's emphasized so that the patient understands, for liability reasons, what is in our reach, and if it's not in our reach, so that they can find the appropriate department to go ahead and go forth with. Regulations and procedures, importance of current healthcare trends. So as we go through, we'll talk about a few of the statistics that we've seen, overviewing risk management practices in specialty departments, and then also liabilities and risks that are associated. So what things are we prone to? What things do we need to go ahead and use more practice with? So we'll go right into it. Slide 3. What is the purpose of an emergency department? Just to overview, an ER provides cares to patients who are in need of immediate medical attention when unscheduled care is required. ER units care for over 123 million patients annually in the U.S. So we can see that quite frequently more people go to an ER than inquire inpatient services. And the whole point is that we're basically trying to attend to the medical emergencies without having to schedule for these things. The things that come up emergent that we need to take care of and prioritize first, that is the specialty of the ER. Between 1997 and 2007, the total annual visits have increased by 20%, while the number of EDs have decreased by 6%. So that statistic's important, and I specifically picked that statistic because we can see that ED overcrowding and a shortage of physicians are large issues with ED. We see that the overcrowding is, I guess, complement to the amount of facilities decreasing. And the total amount of ED visits increasing is because it is more convenient, it is faster. And over the last few years, we've been adopting better practice with EDs, which makes it more convenient for the patient. Moving forward to the next slide, we see the emergency department vital components. So what does the ER consist of that makes it basically run? We have the standards and guidelines. We have different organizations that help for improvement. We have capabilities and staffing. And basically the standards and guidelines, the main routes you'll see, obviously HIPAA plays a large role in regulations and compliance. As far as standards and guidelines go, the other organizations would be COBRA and EMTALA. EMTALA is huge because the introduction of EMTALA was basically stating, regardless of the ability to pay, regardless of finances, we will take care of emergent status healthcare, which is what we are normally seeing now with ERs, regardless of insurance coverage. Improvement organizations, American College of Emergency Physicians, Emergency Nurses Association. So they're really keying in to try to improve on the different ER sectors so that we can deal with this overcrowding and we can get this done faster and more efficiently. Capabilities and staffing are huge. We'll talk about how the ED is organized, and I want to go ahead and key in on how we need to staff the EDs to efficiently run them. Going to the next slide, the vital components continued. I wanted to go ahead and explain the process of the ER, so triage process. The term is derived from the French word trier, meaning to sort out. So basically, the triage is the sorting out process of the ER. And it's classified per levels, with 1 being the most severe, going upwards. So as far as capabilities, you'll know what that specific unit can do based on their leveling. Risks include improper level classification, improper diagnosis, and failure to determine emergency. I think large risks that are associated with triage come in these areas, because if we do not correctly identify the leveling of the triage or the department in general, we can't guarantee the patient those services that they may need so critically. Which is why also on the slide pre-hospital services are mentioned. Those are known as EMS, emergency medical services. Decision making is crucial to patient outcomes because they are the first people to lay hands on the patient. As you see, ambulances, stuff of that nature, what their actions, I should say, adversely will control how the patient responds to treatment. So we need to make sure to properly educate and communicate rules and procedures so that these individuals can go ahead and do the best possible job getting them to the ER so that we can stabilize. The next slide goes with medical record documentation and consents for the ER. This is huge. This is super, super huge. It's vital to managing risk in the ED, and I say that for specific reasons. Most EDs utilize a complaint-specific template, which means they either have computerized or paper-based organization, so that they can effectively track and control what's going on in their departments. Arrival, departure, testing, performance, and consents should all be recorded in medical record. Specifically, the reasoning that documentation is so crucial is because if we need to transfer the patient, if the patient is discharged, their record needs to reflect what happened. Because when they're discharged, that next physician, that next group that treats them will only go by your notes, will only have your notes to confer on the past. So we need to make sure it's as detailed as possible so that we give every specific detail needed to treat the patient effectively. In terms of implied consent is accepted if the condition is life-threatening by the patient's arrival to the ED. So basically, if the patient comes in and we're unable to obtain consent, but it's life-threatening, consent is implied specifically by the fact that that patient showed up to the ED. If a minor has a medical emergency and guardians cannot be reached, consent is obviated, which basically waived, because we need to treat that minor to make sure that they're back up to speed so that we can go ahead and make sure their best interests are in mind. A guardian has the right to deny medical treatment, even if the child is brought to the ED. Basically, what's happening with this is based on religious beliefs, based on personal beliefs, that adult may or may not want to subject their child to treatment, and that's fine. That's their right. As long as the adult is deemed competent, they have every right to deny treatment, and that's just something we just need to be mindful of. Going forward, the next slide is departures, discharges, and transfers. Patients should be stable prior to transfer. That's huge. Again, we need to have the best interest of the patient in mind. A written statement authorizing transfer should be signed by the physician, so the physician should be in the loop and understand what's going on. The original facility must provide the medical records. To reduce liability, written discharge instructions should be clearly written and reviewed with the patient by a nurse or a doctor. Follow-up calls should be made with patients who have high-risk conditions to avoid liability. Going forward to the next slide, we have OB and neonatal liability risks. Infant development allegations related to the birthing process occur due to a delay in treatment of fetal distress. So basically, a lot of the allegations or the litigation that's going on with OB and neonatal is due to our lack or our delay of understanding that the fetus is in distress. Advanced medical technology has enabled physicians to save more infants and has also provided for a larger base of complications. With any new technology, there's also going to be new inhabited risks. So we also need to understand and do our best to balance both to clearly and effectively communicate. Medical documentation and consent must be obtained and documented to defend against litigation. This is key. Again, document, document, document. Next slide is delivery standard and guidelines, clinical protocols, evidence-based algorithms, policies, and procedures should be reviewed on a scheduled basis and as industry standards change. So as standards change, we need to review our policies to make sure that everything we're doing is in line with best interest of the patient. Shifts in public perception and regulations should trigger review, and significant risk management problems can arise if practitioners are not fully aware of policies and procedures. So we also need to keep education as the center as well. Institutional labor capabilities would be the next one. The AAP and ACOG have established staffing, equipment, and support service criteria describing classifications for level of care. So those classifications, those levels that I was talking about earlier, these specific groups dedicated to improvement of the department have set out specific guidelines for those levels so that we can better treat and we have better quality facilities. Level 1 facilities provide services that are least intensive, since your basics. Level 2 facilities must meet all criteria of level 1, but then they must also be able to manage high risk mothers, neonates, and fetuses. A level 3 meets both prior levels and completes even more complex care. This is crucial because most of the professionals in level 3s have specific education in fetal medicine or like diagnostics. So when critical care is needed, their specific education is geared towards that. The next slide being genetic counseling and testing. This has been more prominent in recent years. Prenatal genetic counseling refers to tests that are conducted during pregnancy. So they screen for, they screen to diagnose for a birth defect. Screening tests cannot specifically diagnose, but they can determine if the fetus is at high or low risk. So it gives us a better picture of what's going on. Diagnostic tests identify certain problems or fetal problems such as chromosome abnormalities. An informed consent should also always be obtained. Obviously, for those of you who do not know, informed consent is the practice of going over with the patient both the risks and the rewards of a certain treatment and allowing them to make an informed decision to consent to that treatment. The next slide being antepartum fetal surveillance. So fetal surveillance is a big step as well. The ability to monitor the clinical status of the mother and the fetus is key to delivery. Vital to prepping and ensuring a safe delivery for both the mother and the infant. Documentation in the medical record of all surveillance can serve as a major defensive tool when a breach of standard practice is alleged. So when litigation occurs, documentation on the medical record of surveillance shows that we were taking necessary steps to identify potential issues. Examples include the non-stress test, ultrasound, and even fetal heart rate monitoring. The next slide being induction and augmentation of labor. Induction of labor refers to stimulation of the uterine contractions, so stimulation of contractions to accomplish delivery prior to onset. Frequently, labor induction has doubled, and inductions quadrupled in the past 20 years. ACOG, again, has stepped in and established guidelines for the induction of labor prior to spontaneous onset. The next slide being pain management and OB anesthesia. Anesthetic and analgesic agents not only act on the mother, but also may affect respiratory and cardiovascular of the fetus. So this is why it's crucial that we have the correct expertise at hand during delivery and surveillance. Informed consent, again, required. Claims involving general anesthesia were frequently associated with severe injuries and resulted in higher payments. OB anesthesia services should be supervised by an anesthesiologist or a certified nursing anesthesiologist. So we should always have at least one anesthesiologist or a nurse anesthetist on hand. Pre and post anesthesia evaluations should always be conducted and documented, again, for liability and litigation reasons. Types of deliveries include vaginal, C-section, and vaginal birth after C-section. So vaginal is the most common. Forceps and vacuum extractors are used to assist in removing the fetus from the birth canal. C-section is performed in response to a variety of different reasons, but decision-making dependent on physicians' concerns about malpractice litigation and the mother's desire to select the date of birth. Vaginal birth after C-section is if hospital stays are genuinely shorter with this kind of service. Anesthetics may decrease and surgical risk is eliminated per the vaginal birth. The next slide is neonatal resuscitation and management. Resuscitation skills are essential for all healthcare providers who are involved in delivery. The transition from the fetus to newborn requires intervention by a skilled individual or team in about 10% of all deliveries. National Resuscitation Program was implemented to create infant resuscitation guidelines. That's big because, again, education is key. To better understand and to better treat the patient, we need to be aware. Documentation is a must to avoid forms of litigation. APGAR scoring, umbilical cord, and placental exams. APGAR was developed in 1952 as a simple and repeatable method for rapid assessment of newborn children immediately after birth. So this tests the reflexes and stuff of that nature to better assess any possible issues. Umbilical cord blood acid test is basically a more objective method to go ahead and assess the baby as opposed to the APGAR score. Placental examination may reveal the cause of a preterm labor, premature, rupture, fetal undergrowth, and so on. The next slide being family attendance and videotaping. Staff should be reminded that a video is permanent record, and that what they do and how they conduct themselves during delivery will be recorded if there's patients on hand, which 90% of the time people are there during the delivery of the baby. Most hospitals have a policy that provides guidance for staff defining when visitors attending should be asked to leave or when they should cease the filming. Whenever protocol or decision, in the event that visitors are filming, that needs to be put into the medical record, again, for litigational purposes. The next slide being medical record documentation. It's important that medical documentation be accurate, objective, and complete. Again, litigation has been a growing area for healthcare. So we need to protect the best interest of both the patient and the hospital and make sure that we're fully documented. Documenting during the delivery should include the condition of the mother, the fetal station, and the fetal status. Postpartum documentation should include post-delivery exams and clinical indicators. Neonatal services, so NICUs, are referred for infants who are medically compromised or who may need more intensive care. For routine births, neonatal services pose few liability risks. By comparison, premature births with premature births, more expectation of malpractice claims are heightened. Premature or otherwise compromised infants require a significant amount of clinical support during the first few weeks after birth, because we need to make sure that their reflexes, their neuro symptoms are all in line with where we would like them to be, or at least improving. The next area was infant transport. An infant's medical condition may require transport to a facility. If our leveling is not up to par, we need to transfer that patient to make sure they receive the correct care. Level 2 and 3 facilities treat infants born at the respective families, as well as infants transferred from lower level facilities. So again, we're transferring these patients there. Before transfer can occur, the sending facility must contact the receiving facility to ensure acceptance. So they need to make sure that there's a bed, they need to make sure that there's appropriate equipment, and so on. Copies of all records, tests, tracings, any kind of medical record, again, should be transferred with that baby to make sure that they receive the best possible care and that the physicians have the best possible knowledge. Infant abduction, the next slide. Every infant abduction is a crisis to the hospital, physician, staff, and family. There is never justification for abduction. The number of infant abductions appears to be declining, so that's a very good sign. Obviously, we're doing better because the numbers are coming down. It's in large part because of proactive measures, so education, and we're even shortening stays in hospitals. So typical characteristics of the abductor are a female with no criminal records. An integrated approach to designing an infant security program is definitely recommended as well. We're going to go into negligence and malpractice with this next slide. Surgery and accompanying anesthesia are, by their very nature, risky. So many of the events are related to surgical misadventures. So wrong body parts, wrong patients, wrong surgical procedures. We talked about the types of errors and so on, and we kind of understand where negligence lies and where malpractice lies. So we just must really remain stringent and continue to review records before we take any further action. The next slide is surgical services and staff. Surgical teams may consist of general surgeons, specialties, family practice physicians, anesthetics, nursing staff, surgical techs and assistants, pump machines, radiology techs, and so on. We want to make sure, again, that we have all of the necessary components to treat the patient. Preoperative assessments is the next slide. Successful surgeries require quality clinical and technical skills of surgical teams. And effective pre-ops. Pre-ops identify any specific issues prior to surgery. So we need to make sure that the pre-ops are specifically thorough so that we can better understand the case for the patient, and so that we can truly understand the situations that we're going in. Intraoperative risk issues is the next slide. Basically, when it comes to sedation and anesthesia, it must be provided to someone who is qualified, such as an anesthesiologist or a certified registered nurse. The American Society of Anesthesiologists has a universal checklist to follow. So again, other entities stepping in to ensure quality have helped this issue quite strongly. Surgical fires also pose risk and have become more common in recent years due to the extension of different tools and gases that we use. The FDA launched a surgical fire prevention initiative to promote safer practices and to better educate on what to do in case of fire. Post-ops are also just as equally important. The patient's post-op status should be assessed on admission to the unit and reassessed prior to discharge. Monitoring should include the patient's post-operative status, so post-op status, such as vital signs and level of consciousness. Risk management issues concern serious adverse clinical events. So during transfer to the recovery, and also anesthesia, medications, transfusion reactions, and so on. The next slide, medical record documentation. Medical record documentation, again, is key. We've covered this in a sense a few times up to this point, and the biggest reason why is because of how crucial it really is. All of the components we've discussed so far tie into strong documenting and consents obtained, as well as strong pre and post operations, so that we can ensure quality for the patient. Diagnostic imaging is also another important component of that pre-status, so that we can identify specific issues or problems. So that includes x-rays, CT or CAT scans, fluoroscopy, ultrasound, and so on. Malpractice allegations. The most common ones are failure to diagnose, misdiagnosis, and wrong diagnosis. Additional complicating factors include radiology, or like misses. If we missed something on a scan, that would be a large malpractice allegation. Informed consent, over-radiation, and so on. Management of risk, again, just to overview, there's the more important areas are staffing, number 2, credentialing and discipline and procedure. 3 is obtaining that informed consent, so educating the patient on the further steps of their treatment. Staff education and training, again, go ahead and update the staff as need be, or as trends occur, or as new procedures occur, so that everyone is on the same page. Adverse occurrence reporting and follow-up. Quality control systems, so those systems used to regulate and to better treat the patient, and use and adherence to written operating and treatment policies. Guys, just to summarize, my main question to you, and the question I'm posing, is please explain the importance of documentation and informed consents in specialty departments. What are the consequences of improper account notation to the hospital and even to the patient? So we understand the risk to the patient. We understand the risk to the hospital, rather, but to the patient, what are the risks? So go ahead, throw me your best response. I appreciate you guys listening in. Thank you, and have a wonderful night.